through that first part of the procedure? Yeah, great question. And anyone else? Okay. The other thing I was just going to mention about the hormones is that some women here may know that their menstrual cycle, their hormonal cycle predisposes them to pain crises. So that's another risk to think about when you're having these exogenous or external hormones applied to you. We will talk about the testing of embryos in a moment. And I think I forgot to say, because this is relevant to thinking about freezing eggs and testing, we'll talk a little bit about testing and genetic counseling around passing on sickle cell trait versus passing on sickle cell disease. So these eggs, whether they're retrieved at any time in the life, whether that is before or after a transplant, for example, these eggs are not affected by a transplant in the sense that they will always be hemoglobin S positive eggs. So when people think about preserving their eggs before a transplant, that egg that they're using in the future is still carrying a hemoglobin S genotype. And some people may go through this after transplant because this is still possible after transplant, even if you haven't frozen your eggs, because it may increase the live birth rate. So same thing, if you've had a transplant, these eggs are not affected by the transplant. It doesn't reset the egg to be an AA or an AS necessarily. Most of them, they will be AS, I should say. Okay, so fertility preservation, we talk about embryo preservation. That means doing that procedure we mentioned, egg retrieval, combining it with a donor or a partner sperm and saving it for later. The benefit here is that per egg retrieved, embryos have a better survivability, so more success. But that means you have to either have a partner that you are committed to having children with, or at least creating embryos with, or use a donor. If you do not, then egg preservation might be preferred. So the survivability is a little bit lower, but there's a bit more flexibility. So the eggs are frozen and then can be combined with a sperm sample later. All the case series that have described the use of these common procedures in women with sickle cell have been pretty positive. So the outcomes seem to be pretty comparable to people without sickle cell disease in terms of the procedures itself and the success of IVF. But we don't have that high quality data yet. More recently, this used to be considered more of a research procedure, but it's increasingly available, but just probably not widely available, is ovarian tissue preservation. So this is really important when we're thinking about stem cell transplant or gene therapy in children who have not yet gone through puberty. So if you haven't gone through puberty, you cannot do this egg preservation procedure. You would have to consider something called ovarian tissue cryopreservation, where they're taking actually a piece of ovary. What's really sci-fi and cool about this is that they freeze that piece of ovary, and when it's time, then woman is ready to think about doing egg retrieval with that tissue, they put it in her arm. So the ovary doesn't actually have to go back in the pelvis, where it's kind of hard to get at, and you have to go through a more painful procedure. They put it in the arm, and the ovary tissue does its thing. All the follicles are there. They do all the same kind of stimulation with hormones, but then they just have to go into the arm with an ultrasound rather than into the pelvis. So I don't know where this is available. I think it is available in some higher acuity or tertiary fertility centers. And there is the flip side available for men as well. And maybe Madeline will mention that, I'm not sure. Costs are really important, of course. So there is an Ontario fertility program that covers fertility treatment. So IUI, that intrauterine insemination or artificial insemination, can have as many as you want, covered by the government. One cycle of IVF is covered by the Ontario fertility program. The only main eligibility is you have to be under the age of 43. Fertility preservation, so the egg retrieval and preservation or embryo creation and preservation, is only available if you are receiving a treatment known to cause infertility. So at this point in time, something like hydroxyurea would not qualify, even having the disease of sickle cell, where it seems suggestive that this is a disease associated with infertility, not yet eligible. It would be things like exposure to chemotherapy and stem cell transplant that would make you eligible for coverage. That being said, there are some really high quality insurance programs that might cover this sort of thing, where they have a fertility fund as part of your insurance and you can use it as you wish. The things that aren't covered, even though the cycles are covered, and this is important, are the drugs. So every time you do an IVF cycle, you would have to pay out of pocket or have your insurance cover the drugs, and it's about $5,000 per cycle. For the kind of more simple procedures like artificial insemination and IUI, the drug cost is about $1,000 per cycle, so it's not nothing. Genetic testing is also not covered, again, even though this is a genetic disease. And this is really important, again, when we're thinking about reproductive counseling and the choices a couple or a patient might make about having a child with known sickle cell disease. So there is pre-implantation genetic testing. So this is on top of the more common and long-standing procedures like amniocentesis, where you do genetic testing on fetal tissue. This is taking a few steps back. So you go through the IVF procedure, you collect eggs, you create embryos, and then those embryos can be tested for genetic conditions. So they do perform testing for sickle cell by taking a few tiny cells that are not fetal cells. They're part of the kind of placental or other developmental cells, so it doesn't take away tissue that will become a fetus, but has the genetic material so that the testing can be done. Again, not covered under this fertility program, $8,000 to $10,000 for the testing. And again, if you have a fertility fund in your insurance, maybe it would cover some of that, but it's definitely not cheap. And then finally, storage. So fertility preservation, you're doing that in a 8-year-old, you're talking about storage for sometimes decades, and that is not covered by the fertility fund through Ontario. So I hope that's not all doom and gloom when I finish on the costs, but I think a few takeaways. So I really feel strongly that reproductive health is part of comprehensive care. We should be talking about reproductive plans, fertility, reproductive health early and often, and that might just be with the question, how do you feel about starting your own family one day? So I think that this is a conversation you can have with mature children, with transition patients for sure. And that includes having discussions about contraception, preventing unwanted pregnancy, about pregnancy itself and what it means to go through pregnancy with sickle cell, about fertility assessment and preservation, which we've mostly focused on today, and then genetic counseling, which we've also touched on today. All right. I also think that this has brought forward a lot of questions or a glaring light on the fact that we need to look at this a lot more deeply, and we have a lot of research questions that need to be answered. And these are particularly apparent, the knowledge gaps are particularly apparent in women. There's a lot more known about male fertility, although it's also inadequate. And so we need to focus our health on our attention on reproductive health, because we've had success, we're making it to reproductive age, we're able to live high quality lives, but living a high quality life for many also means expanding your family. And so we need to understand what the mechanisms of fertility and infertility are in the disease itself, as well as what our treatments might do. And because right now it's a bit of a messy web. So in the meantime, having shared care discussions with providers about what it means to be off therapy, what it means to be on something like hydroxyurea, which may have some association, but probably has a lot of benefits that likely outweigh those associations. Those have to be shared care discussions between providers and patients. And of course, then what to do if there is impaired fertility. And there is assistance available, so fertility preservation techniques and assisted reproduction appear to be successful in patients with sickle cell disease, and including those seeking curative therapies. So there are many avenues for exploring this, and all of those factors we discussed might impact them, but I think important to discuss those with yourself, with your family, and with your providers. So that's all I have. Thank you.
Thank you, Dr. Matusiak, for such an informative session. Well-received information, I must say. So now we're going to open up the forum for any questions. I know we're all burning with questions, so we have some time. Absolutely. The mic will come to you once you raise your hands.
Okay, so little backstory. Earlier today, someone asked if someone who has sickle cell disease and they get let's say a bone marrow transplant, they were asking if their children would be unaffected, but we know that's not true because the transplant doesn't affect reproductive cells. But looking at the presentation, and I saw something about PGT, I'm thinking of the perspective of this might be rare, so I don't know if there's any merit in testing, but let's say there are a couple and both of them have sickle cell, or maybe just the woman has sickle cell disease. Is there any research or thought about looking into, because I know for PGT you're looking at unaffected embryos, but are there any researches that are currently being done to look at the eggs of a woman and maybe using I know there's like CRISPR technology that was talked about earlier, like doing testing on maybe the eggs so that they can maybe modify the gene and then do like IVF or something. I don't know if there's any research on that.
That's a great question. I don't know the answer to that. It seems like something that you would hope would be possible. The thing, that we're talking about single cell testing, which I think they can do, but the actual modification. So I'm saying they can do single cell testing for some conditions. I'm not positive about sickle cell, but the modification of a single cell, I don't think we're close to that yet. But that would be something, hopefully something like CRISPR might be able to address.
Okay, thank you.
We have room for more questions, I think, at the back of the room. Nope. Okay. Absolutely.
I'm just wondering, how do you think healthcare providers could help patients better understand, fertility, IVF and stuff like that, even much better? Would you think, like during appointments, if those issues should be discussed as part of regular, topics to address when they come for appointments? Thank you.
You say appointments, Lonray? Sorry.
Yes, like when they come for medical appointments, like at the comprehensive care centers, for instance. Thank you.
Yeah, that's a great. That would be a wonderful addition. I think it is a lot. It's a lot to wrap one's head around, and I think it's a lot to expect all providers to have really comprehensive knowledge of fertility. So definitely bringing in consultation is really important. I think that our job as hematologists or as the nurses or anyone else working in the comprehensive care clinic is just to ask the questions and start the conversations. And then when it becomes beyond our scope, is referring. So it would be wonderful to partner with fertility specialists who would be willing to come and do consultations as part of the clinic. And barring that, or until something like that is available, then I think having a low threshold for those kinds of consultations and referrals is really key. So a common definition of infertility, in an adult woman would be not able to conceive after 12 months. And in the fertility world, if you have other risk factors, say for age reasons or medical reasons, they might shorten that to 6 months. So they say, at 6 months, if nothing's happening, get that fertility consult. And there's no official guideline, but I think some of the expert guidance on that would say that would apply to patients with sickle cell. But I think also just taking that, like rewinding or going back in time, like talking to your transition patients, your teenagers about this, because we're starting to understand that fertility preservation may actually be indicated in some patients. So having that conversation, putting it out there and asking if they're interested in consultation and referring to a fertility specialist to kind of continue that conversation would be, I think, a reasonable thing to do for now.
Awesome. I have a question for you, actually, Dr. Matusiak. So you mentioned that there is evidence of decline in ovarian reserve in 25% of patients with sickle cell disease under age 21. I thought that was really interesting. And in that particular like statistical study, I guess, case study, was it like associated with, correlation with like disease severity, like, patients who probably more likely to get pain crises, have more triggers associated with, hospitalizations, et cetera? Is there any association there?
The association was with hydroxyurea in that study. I don't believe they collected data on things like vaso-occlusive
Okay.
crises. They looked at, I believe, genotype and age and controlled for those types of things, but hydroxyurea, which is in many cases a surrogate, as we know, for severity, was the main association.
Okay.
So obviously that makes people, but that's why I think really thinking in, like, is hydroxyurea just part of the downward cascade of why sickle cell is causing problems with fertility, or is it actually causative? We don't know enough about that, and we do have conclusive evidence about the benefits. So I think it's just kind of something to talk about with your patients.
That's great. And I have one last question if no one else does. Do we have any other questions? We do. Perfect. Go for it, Chloe.
You mentioned something really, really interesting, and I guess it's pretty novel as well, the ovarian tissue preservation. Maybe you could elaborate a little bit more about that in lay terms, if possible. This is for, I guess, preteen individuals, maybe before they're
Before they're menstruating.
ovulating?
Yeah,
okay.
before they're ovulating, because we can't use drugs to
Yeah.
push those follicles out. And so follicles or eggs
Right.
live in the ovaries. So we're born
Yeah.
with all of the follicles, all of the eggs that we will ever have, and they're in the ovaries. So in a prepubescent girl, they would take a piece of that ovary and store it in a freezer. And then the eggs are young and healthy eggs. And when it's time, they thaw that, implant it in the arm, and then they do the exact same thing as we would do for any other egg retrieval, which is to use hormones to stimulate follicles to be produced in there. And rather than having to do a procedure that's through the pelvis, they can just get it through the arm.
Okay, so then the eggs are actually forming in the arm, and that's where you extract it.
Yeah, so the eggs
Okay.
are already in the ovary, and we put it there so that we don't have
Right.
to put somebody through unnecessary procedure to get
Does
it.
that mean that they can't go through natural pregnancy?
They can, so they're only taking a small piece. But this is all like a plan B. This is all backup, right? Where we know that the chemotherapy and radiation treatments can significantly impact fertility. That doesn't mean that nobody who gets those treatments can get pregnant spontaneously, but it really impairs the ability to. And so this is kind of the backup plan. So somebody can go through stem cell transplant and then try to get pregnant naturally, but this is kind of, I have this in the bank.
I had another question on a kind of different thread. Hydroxyurea in pregnancy. What's the current recommendation for whether or not women who are planning to get pregnant, should they stay on hydroxyurea when they're pregnant? Should they stay on hydroxyurea? And so on and so forth.
Yeah, the latest guidance would be that it's reasonable to stop when you have a first positive pregnancy test. That's expert guideline. That's not supported by evidence that's looked at, stopping or not stopping. The old guard used to be stop 3 months before trying to conceive, but you might understand that it can take 6 months or 12 months to get pregnant, and that time off of hydroxyurea can really compromise one's health. And there is not any human data that suggests that exposure in those first few weeks, say if you don't know you're pregnant yet, has a high association with anomalies or with fetal demise. So the current guidance would be, if you're actively trying to conceive, be mindful and try to identify when you have a positive pregnancy test and stop at that time. But we typically don't continue through pregnancy. There may be case-by-case bases where that's considered. An extreme example would be somebody who really ought to be on transfusion, say, because they have indications for transfusion for previous severe pregnancy outcomes, but they have many antibodies or they've had a hyperhemolysis, a bad reaction to transfusion, and we're trying to avoid transfusion. They do really poorly if they're off of hydroxyurea, though that might be a case-by-case discussion where we think about potentially stopping hydroxyurea for the first trimester because we want to avoid kind of any interaction when organs are forming, but then consider restarting it later in pregnancy to kind of control symptoms. But to be honest, I've never actually done that in my short time. I just know that's theoretically something that we could consider.
Thank you. We have a little bit of additional time for some questions because our patient speaker, unfortunately, has not been able to attend today. So we just want to open up the floor if you have any further questions. I see we have one at the back of the room. Mike will come to you in a minute to assist with volume. Oh, you're great. Yeah.
Yeah, I mean, I think it's a lot to ask primary care to be subspecialists in this kind of thing. I really think that this is part of comprehensive sickle cell care. So I think that we as hematologists should arm ourselves with at least the knowledge to give patients some basic information, ask the right questions, and make appropriate referrals. So I think that this should be part of the conversation in your comprehensive care visits, and then appropriately involving fertility specialists.
I'm going to ask you one more question. Is that okay? Because your content was very interesting, stimulating for me. I know you mentioned that there is an obvious there's a delay essentially with women young girls having their menses started, right? Their menstrual cycle, and then in menopause, it's earlier. Are there any case studies around what is the association there? What is the cause? Is it something that, hormonal disruption because of having the sickle cell trait and disease, et cetera?
Mm-hmm. Hormones are the reason why we start menstruating, and so it probably is a delayed maturation of that hormonal axis kicking in. I believe that's the mechanism that's been proposed. And then similarly, things like that AMH hormone and the other hormones that have to do with menopause they're really a reflection of the ovarian health and the follicles remaining in the ovary. So that decline in AMH is probably also reflected by a decline in the ovary or the hormones that continue to stimulate menstruation.
Any further questions? Yes, we have one right here.
Thanks. Hope you can hear me. Yes. Thank you for your talk very much. I think I saw a lot of folks thinking, listening, noting, and so we know that this is an important topic for folks. And I appreciated that question about when we should start those conversations and from what point of entry. I think it can be challenging for folks to come upon it until they need it and they're in it. Mm-hmm. And I think those early conversations matter. My question is about some of the barriers to accessing the technologies and opportunities we have. And I wonder if you have a moment just to comment on some of the reasons people might be hesitant or have felt this wasn't a pathway they could pursue in your experience. Maybe there's more that we can do to not only raise awareness, but maybe demystify some more things. So appreciate your thoughts on that.
Sure. I mean, the financial barriers are the things that stand out to me. That's a very real barrier. And interestingly, in the states, when I was kind of reading about this, some U.S. states have actually passed legislation to make fertility treatment covered by Medicare, particularly for patients with medical reasons why they need to access fertility care. So that kind of movement is probably something that we could work towards here, because it's great that there is some coverage. It's nice that people can access some things, but $5,000 per cycle of IVF is not nothing. And then accessing the genetic testing on top of that, not to mention IVF is not a one-time appointment. It's going in multiple times a week. It's very expensive just kind of socially to be missing work, having to get childcare covered if you already have children, traveling to and from these fertility clinics, which can be few and far between depending on where you live. So I think just the financial and access that way is a huge barrier. And hopefully, like I think legislation is probably something that some of these states have modeled to address that. And I think we just, I started with this, like we haven't really had the opportunity to think about this until recently. I mean, recent meaning like in the last couple decades, but people were not making it to adulthood in the kind of shape, the medical condition where they had quality of life and could think about expanding their families in an intentional or meaningful way and when they felt ready to do so. And so I think it's, we've been very focused on disease modification and that care, which is the main priority, but now we have to think, okay, what do we do now that we've made it here? Not that we've made it all the way, but we're starting to have longer, more healthy lives, and having a healthy life and a meaningful life for a lot of people includes good reproductive care. And I mean, I think the final thing is that Black maternal health is a huge issue to unpack, and mistrust of the medical system. There is a history of non-consented sterilization and medical procedures on women's bodies and reproductive organs. That's a very meaningful history that is hard to kind of distill into it's this issue or that issue, but that really permeates the atmosphere when you're talking about fertility care and allowing doctors to access your eggs and access your reproductive organs.
We have another question on the back behind.
Like interpreters on site. So families are expected to bring their own. Sorry, what I was saying, if you didn't hear me with the mic before, is that many fertility clinics don't offer translation like interpretation supports. So families are expected to have their own family member or support person, which when we think about privacy and healthcare and all of that kind of stuff, it's not always the most supportive kind of space to do that, or it doesn't feel very great to have to do that. And so I think that that's one thing specifically in our clinic that we've seen come up a lot recently is just the fact that families are on their own to try and find interpreters, and if they don't want, like if they're not comfortable using a family member or a friend, which is completely understandable, they are then they need to pay for the interpretation, which is very super expensive. So I think that's just an additional barrier and thing to think about, and a lot of kind of how we bring that into conversations when we're talking with families about it, because that's an additional step to have to kind of think about. So just to bring that up as well.
Thanks, Sarah.
Thank you. Awesome. Okay, well, if there are no further questions, please join me in thanking Dr. Matusiak for such a wonderful, informative session today.
Thank you.
Thank you.
Thanks, Timmy.
Exactly. So please kindly take 5 minutes to provide your feedback. If you will scan the QR code and select the session, please, so we'd love to have your feedback. Dr. Matusiak did such a wonderful job today, and we'd love to hear if, future sessions you have any input. Your feedback is very valuable. Thank you.
Thank you, Dr. Powell. Thank you, Dr. Matusiak. In addition to that, we're a little bit ahead of schedule, so please take a time to get refreshments, bio break, and then we'll come back and have the plenary session in here at 2:30. Thank you.